Okay, thank you for the introduction. So sorry, I just jumped off because it was not my presentation, so I didn't know what to say. Well, this is a very important trial because it encompasses two very important things, which is myocardial infarction and heart failure. It is the study of sacubitril valsartan following an acute myocardial infarction, and it was presented in ACC this year. As we know, there is improvement of all-cause mortality post-myocardial infarction seen from the ACE inhibitor studies SAVE, AIR, and TRACE. And this is important. If the patient is having signs of heart failure, whether symptomatic or echocardiographic, giving a RAS blockade, especially an ACE inhibitor, and later on followed by valsartan, this is good. So the mortality has been seen there, and as you can see, the best mortality comparatively was seen with ramipril. So what was that? Then in 2014, we had a breakthrough in HFrEF. The best in class for treatment of patients with a reduced ejection fraction is sacubitril valsartan, and it showed significant improvement over enalapril. No talk about that. There's no, you can see the P waves. So many zeros, it really is mesmerizing. So in PARADISE MI, those with an acute MI, acute coronary syndrome, within the first day to the first week, with an ejection fraction below 40, or pulmonary congestion, and any other risk enhancers, the ones you see, which increase the risk of patients with an acute MI, and an exclusion criteria of a GFR below 30, and they were really comparatively comparing sacubitril up to the 200 milligrams twice per day to the best in class of ACE inhibitors, actually, and I really recommend that you look at this data. And I have to commend Novartis because they did this against ramipril. And we know ramipril is probably the best when it comes. Dr. Ahmed, انت مش سامع عندها حضرتك كده؟ طب انا هرفع هنزل برقبتي بقى شويه حاضر. So ramipril, which is the standard of care, as seen from so many data, from HOPE to Transcend to On Target, so it is a cornerstone for protection of the cardiovascular system. So it recruited patients from all over the world, and actually they were randomized to 2,800 per arm. And it was looking at those patients post-acute coronary syndrome who have an impaired ejection fraction. As you can see, the average age was in the 60s, and there was a significant presence of diabetes. It's nearly 40%. And you can see the data from the hypertension was not as high as certain other studies. Most of the patients had a STEMI as regards to a non-STEMI, and a lot of them had a reperfusion, nearly 90%. And they were taking the standard of care, as you can see, whatever, if it's the anti-ischemic or the other blockade. What happened? There was a reduction of endpoints, and the endpoint, the primary endpoint, was cardiovascular death, first heart failure hospitalization, or outpatient heart failure. This was reduced by sacubitril valsartan, but did not meet the statistical significance. You can see the curves are diverging as we go along, but still the P wave did not reach the statistical significance. But this is really important. So if you take each endpoint per se, was it cardiovascular death, heart failure hospitalization, or outpatient heart failure, none of them reached the statistical significance, and collectively, as you've seen, they did not collectively. But there were some points to consider, like the age group above the age of 65 and those who had a PCI. These patients really benefited more from the addition of sacubitril valsartan. And if you're looking at the secondary endpoints, again, not reaching the statistical significance except for, of course, the endpoint of the secondary endpoint of cardiovascular death, total hospitalizations, and when you add myocardial infarction and stroke, it had a borderline significance as seen with a 0.045. But when looking at the investigator-reported outcomes, these have shown a significant reduction in the outpatient incidence of heart failure, and we know sacubitril valsartan really excels in reduction of heart failure hospitalization. And also when talking about the adjudicated primary events, again, but of course, these are not the primary endpoints. These are secondary and sub-analyses, and these have shown a little bit of significance in favor of sacubitril valsartan. But what is more reassuring are the adverse events. You can see what the adverse events, there was significantly less cough. There was an increase in hypotension, being a more potent antihypertensive medication. Protection of the liver was better with sacubitril valsartan, but elevation of serum creatinine, potassium, and all other renal endpoints or liver endpoints were met without any increase. Also, discontinuation was less in sacubitril valsartan thanks to the decrease in cough, but an increase a little bit of hypotension. But again, you can see that both medications were quite very silent in their adverse events. If you look at the all-cause death, and all-cause mortality hasn't been reduced a lot in cardiovascular medicine, but again, there is a trend towards reduction without a significance. But what is really striking, if you look at the death rates and the mortality rates from SAVE, AIR, and TRACE, and even Valiant, they were much higher than the data provided by Ramipril in the new PARADISE MI, and so is sacubitril valsartan. Why is that? Because we're treating the patients quicker, better, more primary PCIs than just giving thrombolytic therapy and just medical therapy. So this is one of the explanations that sacubitril valsartan did not meet what we say the superiority over Ramipril. And this is just a summary. You can see that there was no significant reduction in the primary endpoint, even though in the secondary endpoints of cardiovascular death, total hospitalization, myocardial infarction, stroke, it just touched the significant point. And this was the summary presented at ACC, that sacubitril valsartan lowered the rate of cardiovascular death, but not significantly more than Ramipril. These observations of the investigator-related observations of the primary endpoint showed a predilection of better outcomes with sacubitril valsartan, but the safety and tolerability, which is very important, was better in both arms, and sacubitril better even when talking about dry cough. I would like to stop here for a discussion. When I heard about this study, I said, why is Novartis doing that? They have 50%, 45% of paradigm MI, post-MI patients. But actually, if you think about it, this was a very courageous thing by Novartis. They had to do it so they can get, an indication for post-MI. It's not a failure, it's a success, just like valsartan did in Valiant. It's the only ARB that can be given post-MI. So this is a very courageous point by Novartis. Is sacubitril valsartan questioned after its comparison to Ramipril? We know versus enalapril, it did very well in paradigm heart failure. I don't think so. Patients are rather similar. They're not exactly the same. They're not chronic heart failure. They're not the acute heart failure seen in Pioneer. But also, this is another important point to take in consideration. It is still the best medication when it comes to HFrEF and certain parts of HFpEF. So these are just elaboratory points I would like to raise, and thank you.